Thank you, Chairpersons. At the outset, I would thank our entire DRS team, Manoj Chalaji and Puri Chalaji, for giving me the great opportunity to talk on this important session on novel biomarkers. Friends, this session is important because of the advent of modern medications, we know how to protect the vascular endothelium, but we know how to protect the cardiac myocardium also. But we have some challenges on preventing the prevalence of pre-diabetes or impaired glucose tolerance, and also preventing the prevalence of complication among the diabetes patients. So we need appropriate markers. So we are in the era of precision medicine. We are practicing the modern diabetology. So we want to invest our knowledge in the field of precision medicine to algorithm accordingly to prevent the prevalence of diabetes. The power of prediction is very, very important. For that, we need the biomarker. This is the definition given by Professor A.R. in the Indian Diabetes Prevention Program. An ideal biomarker should be redefined the identification of those at risk of a disease or progression of disease, improve the prediction of cause. The power of prediction is very, very important. Which patient going for pre-diabetes? And if so, we how to mitigate the prevalence from pre-diabetes to diabetes. We want to stop the progression of pre-diabetes because we have almost 130 million population of pre-diabetes in India, according to the data given by Professor V. Morgan in ICM in Diet. So biomarkers for diabetes should predict the onset of diabetes in non-diabetes subjects. That is very important message. This message once again by Professor A.R. Biomarker can be added to conventional risk variables to improve the power of association or prediction, including the impaired glucose tolerance and also including the cardiovascular burden. We know that there is increase in the prevalence of pre-diabetes. Pre-diabetes, 30 to 40% of the pre-diabetic population may progress to the diabetes, and also some patients will progress to normal. So we need biomarker to identify how to prevent the progression of pre-diabetes to diabetes, and also the pre-diabetes hyperinsulinic state that is highly atherogenic, and they pay for the cardiovascular complication. Now we need the inflammatory biomarkers among the pre-diabetic population or diabetic population. How we can prevent the cardiovascular burden or impact in that group we want to analyze. This is the prediction graph published in Lancet in 2018. This shows some patients will have the complication very early and some patients will have the complication late onset. That may be 7 years, 8 years, and 9 years. Already we have multiple clusters. We have the inspired data. We have multiple clusters in diabetes like that. The fast progression of complication, slow progression of complication, we want to identify why, what is the need. So, whether there is any genomic play, whether any metabolomic play, any proteomic play. So, these we need the omic approaches. This omics consists of genomics, DNA model, transcriptomics, RNA model, proteomics, once again protein assay. With these means of clusters with the study population, we want to generate a collection of data, biochemical data or biomarker data, we want to implicate in our clinical practice for the research purpose, because these plays an important role to prevent the prevalence of diabetes as well as the pre-diabetes. So what is the ideal biomarker? The center shows the characteristic and the periphery shows the specification and presentation. The ideal biomarker should be sensitive, predictive, specific, and also robust. And we want to implicate in early detection of diabetes and access the acute and chronic complications and the selection of therapy, because we are in precision algorithm, right patient, right treatment at the right time. That we want to follow the holistic approach in our clinical practice. The timeline, these are various timelines with the various category of level of progression of risk factor, pre-diabetes, diabetes, and complications. So there are various biomarkers implicated, including from the adiposopathy and also glucose dysregulation, microscopic complication, macroscopic complication, cardiac myocardial complication. So there are variable biomarkers. I will elude one by one. These are the biomarkers. We know the traditional biomarkers, HbA1c, fasting sugar, OGTT, and some other traditional biomarkers are there. And we know about the type 1 diabetes biomarkers also, like genetic disorders biomarkers and T-cell biomarkers there. And the left side you see the multiple biomarkers are available, but we are not practicing in our clinical diabetology. Why? So we want to analyze some one or two important biomarkers, and we can combine the biomarkers so that we can easily access the patient, and early screening of patient also is mandatory to prevent the complications, including the diabetic population as well as the pre-diabetic populations. So these are our traditional biomarkers, HbA1c, fructosamine, glycated albumin, and also 1,5-AG. So these are the traditional biomarkers. These are a very good diagnostic tool, predictive tool, but the complication is very, very alarming here. See, the complication cannot be predicted early, even though Wikipedia's data shows that every 1% increase in HbA1c, there is 26% increase in microscope complication and 14% increase in macroscope complications. But it is available at the late onset only. But we need the biomarkers to predict at very, very early. That is very, very important. That is, need to identify the novel biomarkers to detect the early stage of diabetes, including the pre-diabetes patients, and also to prevent the complications, especially cardiovascular complication burden among the diabetic populations. Vitamin A, the right side you can see the various biomarkers have been attributed in the IDPP program, that is India Diabetes Prevention Program, which is very, very important slide, my dear friends. They have invested a lot of biomarkers in IDPP program. They published in 2003 itself, before, after the coming with the Framingham data in 1996. Even Framingham study doesn't innovated the importance of novel biomarkers, but Professor A.R. clearly mentioned the importance of novel biomarkers, adiponectin, retinol binding protein A, interleukin 6, leptin, vistat, and vitamin A. This vitamin A is one of the important biomarkers because these have the importance of hepatokines, that is hepatocytokines. This detects the pre-diabetes at the early stage, even before the onset of pre-diabetes, 5 to 6 to 7 years before the duration. That is very important. And it is 90 to 100% accuracy. Ceramides is the lipid molecule. The increase in the activity of ceramides have the impact and burden of both insulin sensitivity as well as the increase in insulin resistance. And it makes the leptin resistance. It aggravates the ghrelin activity, and therefore there will be more and more adiposopathy. Adiposopathy is culprit mainly among the Indian population, and that can be prevented if you see the ceramide activity more among the Indian pre-diabetic or diabetic population. Combining of the alpha-hydroxybutyrate is an important thing because this is a catabolic outcome from the amino acids. The combining of the both the alpha-HB as well as the LGPQ have the import, because even with the one biomarker is very, very difficult, but if you combine the biomarker, but the power of protection will be more on analyzing the pre-diabetes as well as the diabetes patient going for the complications. Adiponectin, we know that adiponectin is an important biomarker of the insulin resistance. That is very, very important for the insulin sensitivity also. It is prevalent about both in lean diabetics as well as the obese diabetics. And also it's very important hormone because this adipose tissue hormone, it prevails the adipokine because this hormone itself have been published in Lancet in 2003 by Professor A.R. once again in IDPP program. See the right side of the graph, it shows increase in the activity, that is decrease in the activity of adiponectin, that is increase in the prevalence of both pre-diabetes as well as the diabetes, and also the diabetic population can be easily go for the complication including the vascular inflammation and myocardial damage. So pre-diabetes correlation in offspring, those the parents having the diabetes, we can easily identify the parents and we can select the criteria for their children to prevent the complications including the pre-diabetic diabetic population. Wonderful data published in 2003 by Professor A.R. in ADA and published in Diabetes Care and Lancet also. Low adiponectin level was found to be a strong independent predictor. The power of prediction is more than 90% with adiponectin. Adiponectin is one of the individual monobiomarker can be easily utilized in our clinical practice for the early screening and early detection. Another important data is given by the biomarker retinol binding protein 4 because this shows 80% belong to hepatocytes and 20% belong to adipocytes. And therefore this is called as the hepatoadipokine. This shows the prevalence of pre-diabetes, IGT as well as the diabetes population to prevent the complication. Bisphatin A is another important biomarker adipocytokine, makes a revolutionary adipokine with the potential to transform the diabetes screening. This shows the early detection capability should prevent the millions of diabetes cases worldwide, because this makes the adipose more and more vulnerable and white adipose tissue rather than the brown adipose tissue, and therefore there will be increase in the insulin resistance and impaired insulin sensitivity. Plasminogen activator inhibitor, that is very important, because this is a serine protease inhibitor. High activation of plasminogen activity, there is more and more vascular inflammation among the diabetes population. Also, it impairs the glucose tolerance. It increases the insulin resistance and impairs insulin sensitivity. Combination algorithm is very important. So, finding with one biomarker can be do. We can enjoy the benefit of 40 to 50%. But if you combine this bisphatin A and vitamin A, see the odds ratio more than 12. The prediction of analysis will be more and more specificity, as well as the sensitivity by more than 90%. So, combining of the biomarkers will have more benefit among the pre-diabetic population or diabetes population to prevent the progression of complication, or also to prevent the progression of pre-diabetes to diabetes. One of the important, previous speaker was talking about the lipoprotein little a, genetic oriented, genetic inherited substance, low density lipoprotein little a. What are the component of the apolipoprotein A? This increase in lipoprotein A will have the impact of the whatever the compound you give for the LDL control, even with the high dose rosuvastatin combining with SMB, there will be no control of LDL. But if you identify the LPA in the early stages, you can go for some other useful molecule, inclisiran or PCSK9. It is more and more mitigate the problem of complication due to high LDL. That is very important. And also utilizing microRNAs. MicroRNAs plays an important role in identifying the patient, because there are multiple microRNAs. These are non-coding small RNAs. There are large microRNAs which have the high prediabetes, and also small microRNAs with low high prediabetes. So, with the multiple microRNAs, we can easily identify the patients regarding the prevalence of prediabetes to diabetes. And not only that, see, there are this slide shows the various microRNAs having the problem of progression of diabetic population easily for the neuropathy, nephropathy, cardiomyopathy, and so on and so forth. So, these microRNA by means of microassay and also proteomic assay will be more and more helpful to identify the patient both in pre-diabetic as well as the diabetic population. PNP, NT-proNP, these are one of the interesting biomarkers we can easily implicate in clinical practice, because heart failure is one of the menace among the diabetic patient, almost in both preserved ejection form as well as reduced ejection form. Any diabetic patient more than 5 years or any diabetic population with obesity, please do this test importantly. That is the natriuretic peptide, brain natriuretic peptide, clinical practice, so that we can identify which patient having the high prevalence of NT-PNP, so that we can prevent the progression of the diabetic patient to the cardiac failure. That is very, very important. Already we learned from the SAVA-TB data, saxagliptin increase the impact of BNP, and therefore this BNP plays an important role in the diabetic population to prevent the heart failure. Another important marker, inflammatory markers, oxidative markers, interleukin 6, one of the important biomarker, and also along with the C-reactive protein. We already learned about the Jupiter trial. Jupiter shows the primary prevention population itself. The rosuvastatin in small dosage, we can easily prevent the prevalence of both diabetes and the cardiovascular burden by 26%, and also the reduction of CRP by 28%. So, these are the important biomarkers can be implicated in clinical practice, eluding the data from IL-6 and also getting the data from PAI, and we can implicate how the patient going for stress, including the oxidative stress, reactive oxygen species, and therefore so on and so forth. We can mitigate the importance, the burden of the pre-diabetic population going for cardiovascular complications, especially among the diabetic population, obesity population also. ICAM is one of the important intracellular adhesion molecule, one of the gene-related adhesion molecule that is, most of the diabetic patient will have retinopathy in the early stage itself. So this is the problem. So identify the biomarker. So those on both type 1 diabetes as well as type 2 diabetes is very important. We can easily identify each patient going for retinopathy as the earliest. The future directions, dear friends, omnic approach along with the bioinformation. Previously we had one of the important talk by AI. So AI plays an important role. Data mining, imaging, machine learning, neural networks, forest firing, revolutionary biomarkers are important and so on. Therefore, we can implicate this in genomics, microbiomics, metabolomics, proteomics and lipidomics. So there are various omic approach we want to utilize in our clinical. It's difficult only, but for research purpose also, speaker select simple biomolecule like retinol binding protein or lipoprotein A like that. Adiponectin also plays an important role. With this, we can easily diagnose the patient. The going for pre-diabetes population, progression of pre-diabetes to diabetes, and also those the patient having the diabetes, progression of diabetes or cardiovascular complications can be easily identified. Dear friends, these novel biomarkers maybe looks like somewhat controversial, but utilizing the novel biomarker in clinical practice because we are in the era of modern technology. Our knowledge is very good in modern technology, but even in the technology, we couldn't be able to control the complications, especially both macro and microscopic complications. So we have to utilize this with novel biomarkers, both genetic biomarker, proteomic biomarker, inflammatory biomarker in our clinical practice. And we want to prevent the complication and we want to enter the good quality of life and outcome and make our India as a diabetic care capital across the globe. Thank you very much for giving a great opportunity.